The aortic valve is one of 4 valves in the heart, and it's the valve in between the main pumping chamber of the heart and the rest of the body. The aortic valve is susceptible to developing problems that can lead to clinical problems, if you will. The most common problem that we see with the aortic valve is something called aortic stenosis. That's like a blockage or calcification of the aortic valve. And as that gets worse, it's a real problem for people. It causes symptoms, most commonly shortness of breath, and is a real threat to their life if it's left untreated. Patients can present in any number of ways. Oftentimes, they'll simply have a murmur or an abnormal sound emanating coming from their heart that one of their caregivers identifies, and that triggers the diagnostic pathway. On the other end of the spectrum, patients are sometimes incredibly short of breath, suffering heart failure, and the diagnostic pathway leads to the diagnosis of aortic stenosis. And then there's everything in between. Probably most commonly, we see people who either they or their loved ones notice decreased exercise tolerance, a little bit of shortness of breath with activities that they normally could do with no problem. That leads to an investigation that leads to the diagnosis of aortic stenosis. The traditional full name of the condition is senile calcific aortic stenosis. It's kind of rude, right? But it's indicative of the fact that aortic stenosis is more common as you get older. So as people get into their 6th, 7th, and 8th decade, the incidence of aortic stenosis goes way up. And so that's one population of patients. They typically have normal structure to the aortic valve throughout their life, a tri-leaflet or tricuspid aortic valve. And just as they get older, various pathophysiologic mechanisms lead to calcification of the valve, which leads to stenosis of the valve and the problems that we talked about. There's a whole separate population called congenital aortic stenosis, most commonly congenital bicuspid aortic stenosis. These are patients who have an abnormality from birth in the aortic valve, which sets up abnormal processes and sets up aortic stenosis forming at a much earlier age. So bicuspid valve patients we often see in their 40s, 50s, and 60s. But the end result is very similar. Aortic stenosis, the symptoms that we talked about, the symptoms of shortness of breath or decreased exercise tolerance. Whether somebody presents with shortness of breath and symptoms or someone identified a murmur on a physical exam, the most important next test is an echocardiogram. It's a non-invasive test. We use ultrasound to look at all the structures and function of the heart. And with that test, we can get a really good idea for how bad the aortic valve is. With regards to the aortic valve, we typically intervene or fix the aortic stenosis when it's severe. We measure that in a variety of different ways, often can do that completely with a non-invasive echo, and if it's causing symptoms. So even really, really mild symptoms, if the valve is severe, it makes sense to fix the valve because it makes patients feel better, gets rid of the symptoms, and very clearly there's a mortality benefit. They live longer. So that's the mainstay of the diagnostic workup. There are other things that come into play later in the diagnostic evaluation as we're getting ready for treatment. That includes cardiac catheterization or other ways to look at the coronary arteries to see if they are playing any role or would need to be treated concomitantly or at the same time. And then once we're pretty clear that we've got severe aortic stenosis that's causing symptoms, then we move forward with the treatment. In a lot of ways, treating aortic stenosis is, I feel, the best thing or the most effective thing that I do as a cardiac surgeon. And that's because there's tremendous benefit. We make people feel better and live longer. And it comes at really a very modest amount of perioperative or peri-procedural risk.